Hello, guys. We're back here again, and this is our daily drill. So, tumalun, tumalun na, excited na talaga. Okay, so everyone who is here with us, again, thank you for the 300 people who've already joined the group. Again, spread the word of the initiative of this free learning, and we will be creating more drills as we progress in our preparation for your examination, guys. Okay, so if you remember, the second drills that I have intended for us would be focusing on practicing your analysis. Okay, so this is now something that we're going to answer. Okay, this next 10 questions that I posted about 3 or 5 days ago, because I needed to give time for people to actually be um, aware, as well as to answer the questions that I have. Okay, so a little bit when it comes to analysis. Analysis has been a bigger problem right now for most of the people who are taking NCLEX because it is also being assessed. Okay, unlike before when it's just like the concept, right now your clinical judgment is also being assessed, or the quality of your clinical judgments are also being assessed by NCLEX. And one of the pillars of effective clinical judgment is, of course, the ability to analyze the concept effectively. Okay, so how do we approach analysis of NCLEX question or analysis in the actual clinical setting altogether? One thing that I always say, especially to my students who are continually creating the clinical, what do you call this, the clinical judgment activity, because that's part of their curriculum. First, base it on facts. Okay, so what are the facts that is being presented to you at the moment? Second, what would be the care needs? Okay, the biggest problem that we have as nurses is that we are always looking immediately to the diagnosis of the patient. Oh, this patient has diabetes. There is a bias that suddenly builds in our brain that, oh, it's diabetes. So let's focus on diabetes. What to be expected with diabetes. But unfortunately, it goes beyond that. When you're talking about care, when you're talking about the ability of an individual or a nurse to maximize care, there is also a need for you to know what is needed at the moment. People with diabetes doesn't just have diabetes. For all you know, they might be elderly who would already have osteoporosis or osteoarthritis. So pain could be a problem. They could be a very young person who is also obese that has a problem when it comes to moving, or could have a little bit of a skin problem or breakdown because of obesity. So guys, look at it in the perspective of what is actually needed at the moment. That is what analysis is all about. Again, when you encounter this kind of question, focus on the facts and then focus on what care needs are actually being expected. Okay, what is it that is the expectation of the care needs at the current time that the person is having that condition? Okay, so without further ado, let's answer the 10 questions that I have prepared for you in the group. Okay, let's begin with number one. So you have a patient with a chronic kidney disease, and then he is presenting or prescribed with calcium carbonate. So that is the subject. Now, what is your STEM? Your STEM indicates which of the following indicates a need for further teaching. So again, we are looking for a wrong statement. Okay, so let's analyze. Calcium carbonate, okay, new medication for the patient with chronic kidney disease, but look at also your choices, okay? All of your choices is focusing on your medication. So do not overanalyze, okay? Do not overanalyze. One golden rule of NCLEX: do not question the question, okay? The question is pertaining to calcium carbonate as the medication. So what would be the best, okay? What would be the best thing to answer here? Or which of the following here is the best answer that indicates a wrong conception or a misconception of the current condition. Okay, let's begin. I will take this medication with meals. Yes or no? Okay, so it should be taken with meals. Is it a good one? Is it a good answer? Yes, it is an indication of an understanding. So if you answer A, it's good. Okay, let's go to D. I need to chew the tablets thoroughly before swallowing. Do you need to chew it? Mm-hmm. Yes, for better absorption. So D is also considered a correct statement. So which is the wrong statement here? Mm-hmm. So if you will take your medication with meals, by the rule itself, there could not be two answers in a question, and C is the opposite of A. C is the best answer. Okay, why is it not B? Will it lower the phosphorus level? No, it's not. Okay, it would actually work with the phosphorus level in order for you to absorb calcium more effectively. Okay, it's simply because when you have chronic kidney disease, calcium absorption is being compromised. Okay, that's why we needed to make sure, that we are giving it, for people with CKD as their supplement. Okay, taking it on an empty stomach would actually cause it to lose its effective absorption. Okay, so it'll just be pooping it out without you absorbing it effectively. Okay, let's go with number 2. You now have a client who has a chest tube. And which of the following would you report immediately to your provider? Okay, let's have it again. Continuous bubbling in the suction control chamber is it expected? Yes, because your chest tube has one immediate purpose. Why it's placed there? It is for the purpose of removing excessive air that have penetrated the actual pulmonary wall. So you needed to eliminate the air coming from the atmosphere, the positive pressure air, in order for the lung to expand. So that goes hand in hand with B. So between C and D, a cessation of tidalling versus a drainage of 60 ml over the past hour, we would go with C. Yes, because a sudden cessation could actually indicate two things. It is either the lung has expanded, or your chest tube is blocked. That's why you needed to report it immediately to your provider. So an x-ray should be done in order to verify if the lung has expanded, and it's probably time to remove the chest tube or to see where the actual blockage is coming from. So patency as well as that of the actual, the actual expansion of the lung. Okay. Did you have 2 already? If you have 2, very good. You're doing it good. Okay, let's now talk about a laboratory value that we are expecting to see in diabetic ketoacidosis. Okay, diabetic ketoacidosis happens when the body, due to the inability of the body to what? With the inability of the body to absorb or to metabolize glucose because of the lack of insulin, would actually make the body think that it is deprived of glucose. So glyconeogenesis will happen. The body will then trigger the transition or the transformation of protein into sugar. The result of which is that the nitrogen, that is the last byproduct, will then create and build up ketones in the body, which is essentially acidic. So, which is something that we could expect. Beginning with a serum pH of 7.45. 7.35 to 7.45 is the normal, okay? Okay, 7.35 to 0.45. In most literature, this is equivalent as a normal pH. So, is A the correct answer? No. Let's go with letter D, serum potassium. Again, your body will try to actually what? Metabolize protein. So you're metabolizing extra protein and fats in the body that will create the breakdown of cells. And essentially, cells have potassium inside them. And this destruction of cells could also increase the potassium to increase. So in diabetic ketoacidosis, your potassium could either be normal or hyperkalemic. So D is also not expected. So between B and C, okay. So if there is a deprivation of cells, primarily when it comes to glucose, where is the glucose? The glucose is on the bloodstream. And if the glucose is on the bloodstream, it is essentially causing the blood to be hyperglycemic. So if you are going to test a patient with diabetic ketoacidosis, the lowest, okay, glucose that you will encounter is 250 milligram per DL. In my experience, the highest that I encountered was almost 1,200 milligram per DL. Like literally 1 gram of sugar in the blood. Okay, so if that is the case, if the lowest glucose is 250, is B a correct answer? Of course not. Because this is within normal range. So your correct answer is a serum bicarbonate that is 12 milliequivalent per liter. Why? Because your diabetic ketoacidosis is also a manifestation of metabolic acidosis. Okay, and metabolic acidosis is being showcased by a decrease or significant decrease in your pH. Okay, or on your bicarbonate. So anything that is actually below 16, okay, actually below 16. In some books, it's below 20 or below 18. Lippincott says it's 18. Saunders says it's 20 over 20, 20 to 25. Lippincott 18 to 27. So anything below 18, let's put it as the main basis. Anything below 18 for sodium bicarbonate could be considered acidic. Okay, so are we passing? Okay, hopefully we are passing, guys. Okay, so let's go to number 4. You are taking risperidone, or the patient with schizophrenia is taking risperidone. Which of the following will you report immediately to the provider? So let's analyze it again. Which are the facts? The facts is that the patient has schizophrenia, the patient is taking risperidone. Essentially, risperidone is your second generation antipsychotics, also known as an atypical. Okay. Excuse me. This is your atypical antipsychotics. So why did we have atypical antipsychotics? What's the main purpose of this one? Okay, so originally, excuse me, the first generations of your antipsychotics has one main function: to stop all the dopamine from actually flooding your brain. It is believed and of course supported by medical laboratory science, that there is an increase in dopamine transmission as well as absorption and functionalities in the different parts of the brain during schizophrenia. So, in order for you to prevent all of the psychotic tendencies or signs and symptoms of psychosis, hallucinations, delusions, aggressive behavior, impulsiveness, illusions, as well as that of delusions, you need to stop your actual, okay? You need to stop your actual dopamine. So dopaminergic transmission is being halted in your typical antipsychotics. So what are those? Haloperidol, chlorpromazine, molendone, okay? As well as that of those first generation ones, they stop it. Now, unfortunately, when you stop dopamine, there are some areas of the brain, let's say, for example, the parietal region of the brain, that is intended to support the coordination of the body when it comes to movement. And dopamine plays a big part in making sure that that coordination is happening. Now, without dopamine, it will cause pseudo Parkinsonism, otherwise known as extrapyramidal symptoms. Okay, so what would happen with that? What does that tell us? Because of the extrapyramidal symptoms that is happening, that will eventually become a permanent condition, which is tardive dyskinesia, people needed a reprieve from the treatment. And that is where atypical antipsychotics comes in. Because in atypical antipsychotics, it just limits specific pathways of your dopamine, not essentially the entire dopaminergic cycle in the brain, resulting to less EPS to none at all. Especially the newest one, like aripiprazole, risperidone is also one of them. So these medications essentially allows an individual, okay, to live a normal life. Because imagine if having tardive dyskinesia, being in a neuro unit, I've seen it. It's hard. Imagine their tongue is continually just open up, and they cannot swallow, they cannot chew effectively, they're drooling. That would affect quality of life. So that's why you have atypical antipsychotics. So with that at hand, that's a little bit of a background to the typical antipsychotics. What would be the finding that would need provider intervention? Now, if this would be the case, and let's say, for example, you don't know what risperidone is, you don't know the action of your typical and atypical antipsychotics, it is always go with the basic concept of analysis. Which of the following conditions here, signs and symptoms that you are seeing, would create a change or a drastic change with your patient? Okay. That is our analysis question. And nothing could answer it better than letter B. Sir, why not weight gain? Okay. The trade-off with atypical antipsychotics not causing EPS is metabolic changes. So it affects the actual metabolic coordination of the body. That is why weight gain, insomnia, okay, could be a big problem for some. But in most cases, your antipsychotic being decreasing your overall capacity to actually trigger something in the brain, because dopamine is a stimulant, it could cause sedation. Okay, so I already gave the other answer. So sedation could also be a possible side effect. It could go both ways for some people. I've seen some people who have insomnia. I've seen some people who have sedation. It also depends primarily on where the psychosis is happening, because there could be schizophrenia associated with illicit substance abuse. Now, dry mouth. Why didn't we include it? because your antipsychotic has an anticholinergic effect. Essentially, it is stopping the parasympathetic nervous system it's stopping the parasympathetic nervous system enacting up by eliminating the muscarinic receptors. So if the muscarinic receptors are being eliminated, or rather being limited, your ability to release acetylcholine, which is essentially the trigger for your parasympathetic nervous responses, will be out. And that would also eliminate the functionality of your salivary glands, resulting to dry mouth, which is a common sign and symptom. Okay, hopefully you got that. Postpartum client experiencing a heavy lochia and a boggy uterus. What is your priority nursing action? When you're talking about priority interaction or other nursing action, it is independent first over dependent intervention. So when you have heavy lochia and boggy uterus, this is essentially an indication of what? Uterine atony, which in turns creates postpartum hemorrhage, which is essentially the main cause of mortality for our postpartum mummies. So what would be the thing that will help us protect the mom from having unnecessary bleeding? Okay, the correct answer is massaging the fundus. Sir, why didn't we choose letter A? Okay, again, independent first before dependent. Okay, if your healthcare provider is being activated almost immediately, well and good. If you have a provider like available in the next 5 minutes, then you're good. What if that person is going to answer 30 minutes, more likely an hour after you give the referral? Then your patient's dead. Okay, that's the main purpose why we prioritize independent nursing interventions, because we could act, and according to studies and research, individuals that are being given immediate interventions by the nurses will have more survivability. And I always emphasize it in my students as well. Before you do the report to the doctor, make sure you have done something, not the other way around. You are there for a purpose. You are there with a reason. And you are there with the knowledge in order to care for your patient. So use the knowledge first. We could also assess bladder distension, but after we have already done the massage. We need to make sure that your uterus is not boggy and it is constricted in order to prevent unnecessary bleeding. Starting of IV fluid, dependent nursing intervention. You cannot start an IV fluid without a doctor's order, right? So you need a doctor's order for that. That's your number 5. Now, you have a patient who is being cared for and is receiving IV heparin for deep vein thrombosis. So which is the most important thing to monitor? Which laboratory test will you monitor? Okay. So this is like almost a given question. The correct answer here is APTT. So why we're not monitoring hemoglobin? Hemoglobin is an indication of active bleeding. Okay? Or if there is a risk for bleeding. That's the reason why we are looking at hemoglobin and platelets. We want to make sure that there is no active bleeding while you're giving an anticoagulation treatment. Essentially, if there would be a sudden decrease in the hemoglobin and as well as a significant decrease in the platelets, then you are assured that there is a patient that is bleeding. That's why, since both of them are actually being monitored for that one, you're not going to use it. How about INR? INR is a measure for the functionality of warfarin. And in most cases, INR is chronically being activated. That's why it is the therapeutic measurement for warfarin, or otherwise known as Coumadin. Your activated partial thromboplastin time is the one that is being affected, because why? Because this is, okay, your thromboplastin is a factor. It is one of the proteins that is involved in the coagulation cascade, which is essentially the one that your anticoagulant treatment is limiting. Okay? That is why APTT is your main measure. Now, what is the other measurement? And here in the US, that is actually the gold standard. So apart from APTT, right now, we are measuring the anti-XA, or the anti-10A factor. Okay, why? Because your 10A is directly being affected by heparin. It is heparin specific. Your XA is also very useful in order for you to have a pinpoint, okay, a pinpoint and specific measurement of therapeutic level for people who have been using, let's say, your enoxaparin or your small molecular weight heparin. It is also very much sensitive and very accurate for people who have inflammatory disorders. Let's say if you have an autoimmune reaction, such as that of your lupus erythematous, your rheumatoid arthritis, and all of the other autoimmune condition. And finally, this is also very much useful for people who will have heparin resistance, especially for those who have been taking anticoagulation treatment for the longest time. People who have coagulative conditions like chronic DVTs, people who will be taking anticoagulant treatment to prevent the risk for myocardial infarction. Let's say, for example, people who will have AFib, so people who've been taking Eliquis, as well as that of other anticoagulant treatment. That's the reason why XA is being taken. So periodically, best practices, you need to take this, okay, 6 hours after you have adjusted a heparin dose or you have started a heparin dose, in order for you to titrate it effectively to the amount that is therapeutic. Okay, so that's another knowledge for you guys. Let's go to number 7. Which instruction is the most important for you, the nurse, to include when teaching a patient about taking levothyroxine? So levothyroxine is your thyroid medication. So let's have it one by one. Can I take it in the morning with my coffee? No. Okay. Can I take the medication with calcium supplements? If you can take it with coffee, you could also not take it with calcium supplements. Essentially, you need to take it on an empty stomach. Okay, and it is being taken in the morning. Another giveaway question. Hopefully, everyone was able to answer B. Okay. So again, levothyroxine, other things to remember, if ever that the patient will be taking a morning supplement of either a calcium supplement, or in most cases, especially for those who have been working on the SNF, for our LPN and CNA friends there, if you will have an order for a medication, let's say, for example, a Q6 Tylenol, you could not give it, okay, after, or rather with the medication or with levothyroxine. So you need to give your pain medication, your analgesic, at least 30 minutes after you have given levothyroxine on an empty stomach. And for some elderly patient, again, I would advise people to, give them a cracker in the morning before you give them any pain medication, because that's a usual routine, especially for people who are in a skilled nursing facility or a long-term care facility. Okay. How's it going so far, guys? Hopefully you're doing great. Okay. Hopefully you're doing great. Let's go at number 8. A nurse is assessing a patient with myasthenia gravis. Which of the following requires immediate intervention? Okay. What is myasthenia gravis? Myasthenia gravis is a progressive disorder resulting to the inability of the muscles to accept acetylcholine. Okay, so what is acetylcholine? Acetylcholine is one of the neurotransmitters that are essential to impose coordination of the muscles in terms of movement. Okay, I will do a focused content of myasthenia gravis. First thing just to remember, acetylcholine is not being utilized by the muscles on their actual neurofiber layers. Okay, so between the neurons as well as that of the muscles, there is a disconnect and loss of communication of acetylcholine. The result of which is that there is the inability to maintain effective strength and functioning of the muscles. That's why myasthenia gravis is being manifested by severe fatigue. There is also that neuropathic pain, the pins and needles feeling on the lower extremity, and it is a descending weakness. Okay, so always remember MG, moving with gravity. Okay, moving with gravity. So let's say, for example, we are here again. We need to analyze it, but unfortunately, we have a minimal idea, or the brain cram is here, and then you forgot about what myasthenia gravis is. What are we going to do about it? Okay, so again, let's analyze which is the facts and what are the things that could actually modify the care needs of the individual. So if that would be the basis of our analysis with that technique, what would it tell us? Okay, the one that would change the overall course of our interventions and care would be letter C. Okay, because your difficulty of swallowing could actually be a choking risk that will in turn, okay, will affect ADL of the patient. The patient cannot eat. The patient cannot drink. Now that's the biggest concern. The level of care will advance. You now need to make sure that there will be treatments. You need to identify, is that a myasthenic crisis or is that a cholinergic crisis because the patient has taken too much medication? You see? Muscle weakness improving with rest. The word improving, is it something that we need to be afraid of? Of course not. We want to improve. And does it happen, improving? Yes. Because what happens here is that acetylcholine is not essentially going down to the actual muscle fibers. So you could not trigger the action potential. It would take a long time before acetylcholine could actually be used in order for the muscles to react. That's why once the patient with myasthenia gravis rests, strength will come back. Ptosis, or the actual, okay, drooping of the eyelids for patient with myasthenia gravis. Is it normal? Yes, it is. It is one of its cardinal sign and symptom. And finally, a nasal voice, a whispering voice. Imagine a person that is weak. Let's put it that way. As simple as that. Of course, this is also expected. That's why D is your main concern. Again, in analysis, is it something that is a fact with the patient? Is it a fact that there could be difficulty of swallowing, weakness in the throat? Yes. Could it change the level of care that the patient is requiring at the moment? The needs of the patient for the care? Yes. So C is your best answer. Okay, let's go with number 9. The patient is now prescribed with furosemide. Which of the following should you monitor? Okay, furosemide is a loop diuretic. Okay, so what are we going to do with the loop diuretic? What does it do? It increases the functionality and the potency of the loop of Henle in terms of its functioning, resulting with the patient removing more water out of the body. So if it is removing water, the most important thing that we need to find out or to watch out for is electrolyte imbalance. And electrolyte imbalance that we have here, which is very much dangerous, is hypokalemia. Okay, again, hypokalemia could create prolonged QTs. And what is this QTs? This is on your actual EKG readings, okay, meaning the contractility or the, no, contractility, not the contractility, the conduction problem for the heart. So what is the problem if there is a conduction problem of the heart? Ineffective heartbeat. Putting it simply, it could cause very dangerous arrhythmias. Okay? The synchronicity of your heart depends primarily on the integrity of the heart conduction. So any changes in the heart conduction could be fatal to a patient. Why is it not bradycardia, sir? Again, you're losing water. The body will perceive that you are dehydrated and the body will compensate. How will the body compensate? Tachycardia, not bradycardia. Okay, our correct answer is hypokalemia. So the direct opposite of it is the wrong answer. That's why you're not going to answer hyperkalemia. You're taking furosemide in order for you to release unnecessary and excessive water in the body, which could be associated with either the presence of what? The presence of what? Let's see. If you're thinking congestion, yes. If you are thinking hypertension, yes. Okay? Furosemide or your Lasix is your main medication to prevent excessive edema plus hypertension. So, is hypertension we need to monitor for? No, it's a treatment. It's a treatment for it. Okay? So, hypokalemia is your top priority. Let's go to number 10. Which client should the nurse assess first after receiving ship report? Plain and simple. Plain and simple. So, airway, breathing, circulation. Let's analyze. Which of the following there has the ABC? This is the only thing that you need to focus on prioritization. That is letter B. Okay? Because that is an airway and a breathing problem at the same time. Breathing in a sense that there is no effective saturation. 88 is already desaturation. Airway because asthma constricts the airway. That's why you have audible wheezing. Why is it not the patient with a hip fracture requesting pain medication? Is pain part of the disease process of a hip fracture? Is it expected to happen? Yes, it is. Is a client that is required to have a dressing change in the next 30 minutes a top priority? No, it's not. Dressing changes, especially for stable dressings that is not having heavy discharge, is your last priority of care, especially in morning routines. Anyone who has a blood glucose level of 150 milligram per DL. Receiving ship report, more likely in the afternoon or in the morning. They might have just finished eating, or they might have just finished their coffee, which they have what? Spilled like 5 Splenda or 5 packets of sugar there. Is hyperglycemia be a possibility? Yes. Is it a concern? 150? No. Remember with our discussion a while ago, if you are going beyond 250, that's where your risk for hyperkalemia or rather hyperglycemia that could trigger diabetic ketoacidosis could occur. So 150 is far away from 250. Okay, more likely that person could still have an increase by the moment you take the blood sugar one more time. But again, airway and breathing problem or compromise is your top priority. Okay, so who got? Okay, who got 10? Okay, if you got 10, message me on the comments underneath this post. But nonetheless, hopefully everyone was able to learn once more. So again, this is a summary. When you are analyzing, go back to the facts and apply the actual evaluation of the care needs of the individual. If you are being given a question of NCLEX focusing on analysis, always prioritize interventions, actions, as well as that of items that will improve or help improve the overall care needs of the individual. If it's a negatively formed question that is asking for complication, look for those that will complicate the needs of the patients. Anything that could be an adverse reaction or anything that could eliminate the client from a possible progressing or rather a positive prognosis is a possible answer. So again, continue to share our initiative for this free learning as well as that of this training group that we have. I will always be happy to answer your questions. I'll be answering some of the questions for everyone who will be posting it in the group. But nonetheless, always remember, you are the only one who is stopping you from gaining your best. So make sure that you don't stop learning, you don't stop pursuing every dreams that you have, and we'll just be here to help guide you in getting that success. Again, this is your coach, Alan. Thank you again for joining me for almost an hour of learning. And hopefully, you'll reach your success. See you guys on our next discussions. Stand by on the group. I'll give more drills, more reels and videos of tips, and how are you going to maximize your preparation moving forward. Bye, guys.